So Dr. Roja is going to be speaking on durability of endovascular aortic aneurysm and giving the Professor Khanna oration this year.
It is an enormous pleasure to speak to you from Imperial College London, particularly to give the M.N. Khanna oration, because M.N. Khanna, the well-known cardiothoracic surgeon, particularly cardiac, was trained in London with Donald Ross of Guy's. I was trained at St Thomas's. They're now joined together. So we have a great link, M.N. Khanna and I, and it's a privilege to give this oration. Today, after the EVAR trials, which I had something to do with, the world's first randomized controlled trials on endovascular aneurysm repair, I've got to tell you, we hit problems. NICE told us that they couldn't fund it anymore, and I'm going to show you what we should have done that we didn't do properly. No declarations of importance there. Let me tell you the problem which occurred. This shows on the top the aneurysm-related mortality, and open repair is in blue and EVAR in red. Below that is the all-cause mortality, and you'll see that at the beginning we were delighted how well EVAR was doing compared with open repair. It was quite obvious that unless a procedure was preferred by the patients, we should do it. Even though I personally love doing the open procedure, it had to be learned. But after 8 years, problem occurred. And at the end, aneurysm-related mortality, as you see at the top, was substantially worse than open repair, apparently, and it stood out. And all-cause mortality on the lower curves, that also looked as if it was a problem. So now let's look at the statistics. And you'll see from the hazard ratio at the top, aneurysm-related mortality, hazard ratio of 5.82, high p-value, very, very significantly worse than open repair at the end. And to our surprise at the time, all-cause mortality was greater in those with endovascular repair. So we were fairly downhearted about it. And then, of course, we looked into it further and found that aneurysm-related mortality was caused mainly from secondary rupture, and all-cause was mainly from those secondary ruptures, contributing to all-cause mortality as well as some cancer deaths. We started to wonder if the cancer deaths were because of all of the CT scans being performed, more in the endovascular and the flora and so on. So let us look at the follow-up. The clue seemed to us to lie in the follow-up that we've been doing, and let's look carefully at this against time. So the proportion of patients who would return is on the vertical axis, and on the horizontal is the time. And you'll see that at first most returned, but by the end, only 10% of the British patients returned for the annual clinical follow-up with CT scan. Either they or their doctors somehow didn't like it. But we thought this could be the UK being awkward, but it turned out not to be. Finland had an exactly similar pattern. They did better than the UK, but and there were more recent patients. 40% only at the end, and very much better at the beginning. So it would seem that the follow-up is not tolerated going back to a hospital for a CT scan. Now let me introduce you to the concept of trajectories. If you're a surgeon like me, you'll need to be reminded what a trajectory is. And most of my medical student days, I thought of sport, and I would like to have been better at cricket than I was. Let's imagine throwing a ball through the air from the boundary. The path it takes is referred to as a trajectory. If you're Alan Lumsden, a Scotsman, you'd probably toss a caber rather than throw a cricket ball, and the path that takes would be, if you like, a trajectory. A poor trajectory at that, Alan. Now let's look at these findings, these trajectories, in the patients that didn't rupture. On the left, either in the EVAR trials in Britain or the Helsinki more recent cohort. The striking feature here is that most of the patients that didn't rupture had a sac which collapsed around the endovascular repair, whereas immediately over to the right, you'll see that both in the EVAR and also Helsinki, the ones who eventually ruptured were the ones where the sac increased. In the middle are so-called RPR, or rupture preventing reinterventions. So if only we had known about the sac expansion, which we didn't because the patients weren't coming back, then we might have been able to send them for a correction of the underlying endoleak, and that rupture preventing reintervention makes the patient's trajectory look a little bit like those who didn't rupture. So that is a pointer to how we can. The brilliant research work was done by statisticians mainly in Cambridge. Michael Sweeting led it. Professor Vernamo is a surgeon in Helsinki, now become the Secretary General of the European Society for Vascular Surgery. But Groos, Barrett, were statisticians, and very clever they are. So we wanted to evaluate the effectiveness of cost effectiveness of surveillance because, you know, the NICE were going to withdraw the funding for endovascular repair, despite the fact that in many countries it's now the standard of care. And the societies were very annoyed and tried very hard to find data to discourage NICE from withdrawing the money. And these are the data that the societies chose to make the case. So based on real data from patients who actually had endovascular repair, we used a little bit of wizardry called discrete event simulation, a little bit like the statistics you hear from Imperial College, Oxford and Cambridge at the moment on COVID modeling. So you don't actually have the data, you model. And let's see what might have happened if we had done it a different way. This is a cost effectiveness chart. Let me explain it to you. Having picked this up from statisticians, which I'm not, but a surgeon and a clinician like many of you, on the vertical axis is the cost. So for a government to buy something, they don't want to pay too much. And on the horizontal axis to the right, it's quality of life years gained. So the further to the right, the more that it's liked, and the more it's cheaper, the better. So what you want to be is a long way to the right and a long way to the bottom. So that's what you look at. EVAR trials, model A, is what we actually did. And you can see that it's pretty abysmal. We didn't know any better, but it didn't save a lot of lives. It was reasonably expensive, but there are others that were more expensive. EVAR trials, B over above 5.5 on the horizontal, you'll see the guidelines telling us how to do it. And if the patients had actually done it, then yes, it would have cost more. There would have been some improvement, but not an awful lot. But Michael Sweeting and the Cambridge scientists and statisticians allowed us to consider a handheld ultrasound device used in the community, which is Model F. And Model F means that if you were to measure the sac diameter in the community and identify those patients whose sacs did not expand, that will be the 44% safe patients. But if we were to use that, you'll see that many life years were gained, not as many as if you were to do the ESVS guidelines, but because C and D were so expensive, governments wouldn't pay for them. NICE draft guidelines are E. That was not very popular because it was achieved by actually stopping follow-up at 5 years. So F is possibly the way forward, and with a handheld ultrasound device to measure the sac growth, it should be possible in the community, close to home, close to the patient's doctor, to check the diameter of the sac. And if the sac starts to increase at all, send the patient back for a CT scan and find the underlying endoleak and put it right. Well, thank you very much for letting me give you those new data. And it's been a great privilege to address you in the Asia Pacific Vascular Meeting. Thank you.
Okay.
Thank you very much, Dr. Roger. As this is the award session and oration session, we actually gave a read out a citation and gave a plaque, but because of the COVID situation, that plaque is cannot be sent to you right away. But as soon as the courier services start and the lockdown is over, it will be sent to you.
Oh, thank you.
So this is what it is. I'm just showing it in the picture, and
it's very kind.
Dr. Khanna.
Yes.
Yeah, Dr. Panja speaking. But one thing I want to ask.
The questions are after, Dr. Panja, the questions are after this.
Okay.
The citation reads APVIC 12 online, the 12th Asia Pacific Vascular Intervention course. Professor Khanna oration for the year 2020 has been conferred on Dr. Professor Roger Greenhalgh from the Imperial College of London, UK, for the topic Durability of Endovascular Aortic Repair at the 12th Asia Pacific Vascular Intervention course held virtually at New Delhi, India from 26th to 30th June 2020.
Lovely.
Distinguished contribution to the field of endovascular surgery. Asia Pacific Vascular Society wishes him many more years of good health and academic excellence. Dated this 26th June 2020. We would be sending it to you, and we are honored that you came in spite of your very busy personal schedule today and blessed this society and gave this oration. And the Asia Pacific Vascular Society hopes to work very closely and in collaboration with the Charing Cross Symposium.
Yes.
This year, we are expecting about 10,000 people to join in. This is also being simultaneously being relayed to the YouTube platform and also the Facebook. So many people are watching this online. And this could be actually relayed. It will be in archives for 3 months, and it can be viewed by people who log in even after this. So after this, I will leave it to the question and answer session, and I'll ask Dr. Sriram to take over. I believe Dr. Sriram is one of your students, is now working in Singapore.
Thank you so much, Professor Khanna. I appreciated it very much indeed.
Thank you so much. We are honored and privileged.
And we can have a relationship with Charing Cross with great pleasure. Always. Thank you.
So now, Sriram, can you take over?
Yeah, sure. Thanks very much. Thanks very much, Dr. Khanna. And Prof, it's a pleasure to see you again, and it's a pleasure to see you looking healthy.
Yes,
sadly couldn't see you in April this year, but I'm sure we'll see you in April next year.
I miss seeing everybody.
Yes. In the introduction, I still remember the one bit of the introduction that was missed was my first introduction to you on the corridors of Charing Cross. Where his first question was, who are you and what do you hope to achieve? And this was his first line to me. He is a legend.
Have you achieved it?
No, because every time I think I've taken a step, I'm sadly confronted with the many steps forward that you have taken. So we are always trying to catch up with you.
I'm dissatisfied with myself.
So, Prof, I'm going to firstly begin the question and answer session with a question based on your new data.
Yes.
Which is that, do you believe if we had understood the surveillance much better?
Yes.
Throughout the course of EVAR, and the way surveillance is done today in terms of responding to endoleaks, do you believe that the results of EVAR would be comparable, if not better, to the results of open surgery?
Fantastic question. Thank you. what I can say to you is that I don't think it was that open repair won. I think it was that endovascular repair lost, and it shouldn't have lost. And so it showed at the beginning how well it was doing. And the surgical profession, which you need to listen to, and the patients prefer it. So there are many operations you will have seen me do, sometimes under which we call the EVAR2 situation, where the patients are so sick you can't have an anesthetic even. We would do under local anesthetic. One instance, doing an endovascular repair under local anesthetic, the patient lay still and we did the repair. And at the end of it, the anaesthetist and I sat down and the patient stood up and gave us a cup of tea in the operating room. We were the ones who were exhausted. The patient was fine. And so even recently at the Charing Cross Symposium, Stefan Halong has done a half an hour endovascular repair and minimal problems with the patient. So the patients like it better, the surgeons like it better. And I think the error that I blame myself for trying to put right now is that we forgot that the patients were started with an age of 74 and 15 years follow-up. Most of them were either dying or certainly not wanting to go back to hospital for a CT scan. That was a mistake. And so this modeling shows that if we only knew this sac diameter in the community, then if it wasn't getting bigger, those patients were safe. They didn't need to go to the hospital. And if it did get bigger, you then say to them, look, I'm not quite certain this is going to be lasting. There's a risk it might burst. They may say, doctor, I'm too old. I don't want to do it. I take my chance. But those who were well enough and wanted it could have an intervention to repair the endoleak. So yes, I think we made a huge mistake, but it's good to look back, see what the mistake was, put it right, and see if that doesn't put it right. And I'm so lucky that at my age, the Vascular Society of Great Britain and Ireland has asked me to be the principal investigator of all the academic centres, the university centres in London, and we're doing a study called the DETECT study. And the DETECT will actually do exactly that, and it's being done now. And NICE know about it, so they know it's on the way, and the Vascular Society knows it's on the way, and we all think that it shows every sign of being very successful.
Prof, just a quick little follow-up. I'm waiting to see if other questions come up on the Q&A, which haven't, but just a quick follow-up on that, because when you first mentioned this at the VSGBI in Glasgow, just before NICE 186 was threatening to come out, I was there in the audience at the time. But just a little follow-up. There was a bit of teaching that went on between the sort of believers and not quite believers. That if your patient is young and fit, then go ahead and do an open repair. And if they're old and a little sort of falling apart, then they should be the ones for EVAR. But from what you say, that the older patient has anyway got a less life expectancy and probably following up, they should have, but we should not consider EVAR to be ruled out in the younger patient, and that we should probably still consider it for them.
Well, it's a tricky problem. You see, as a trialist, I'm principally a surgeon, but if I want to know what to do best for my patients, I got pulled into doing these trials to answer my stupid questions that I had in my head, and surrounded myself by brilliant people who would help me, statisticians and experts. So I really, like you, I want to know whether I can depend on EVAR or not. And I have to say that I wanted to believe the data we were shown. And if you look at the data you're shown of a randomized controlled trial for which I was responsible, what the person said in Glasgow is correct. You could reasonably make a case for offering open repair for a younger person. But then you've got to say to yourself, you're offering a higher mortality for that, and the endovascular repair may have problems going on that needs to be put right. But the initial mortality is about 1.56 or 7%. And it depends what your mortality is for open repair. Ours was 4.7% in the trial, but the average mortality was 10% at the time. So are you going to offer a 10% mortality in some people's hands, or are you going to go for a 1.7% mortality? And for me, I offered a low mortality, and I'd rather maintain a good result. So that's my answer to that.
Would there be any questions more from the panel? Because,
Yes.
There are more, but what we understand the time constraint of Dr.
Okay, okay. Just
He
only
has some
one.
personal engagements. So
Yes.
we would close the session here.
Yeah.
Thank you so much.
Oh. I was only one question, Dr. Khanna. So, is it possible that is presence of diabetes and aneurysm contain thrombi and ulcerative lesion? And what is happening? Diabetes, hypertension, what is the prognosis and what is the survival of 15 years on that group of patients?
Well, I have to tell you that I published when I was a young man on the difference between arteries that go narrow, what I call stenosing disease, coming down into a small, and aneurysmal disease dilating. And in aneurysmal disease, diabetes is extremely rare. Only about 1% of patients who have aneurysmal disease are diabetic. In fact, that's making people ask questions about whether they should be giving metformin or drugs to aneurysmal patients to interfere with their growth. That's not been proven. But there's a very interesting relationship between aneurysmal disease and diabetes, and it seems to be diabetes protects from the dilatation, whereas, as you're well aware, in patients who have intermittent claudication, 10% diabetics, for the ones who have rest pain, 20% diabetics, and the ones who come to amputation, 30% diabetics. So it's stenosing disease, the worse it gets, the bigger incidence of diabetes, but in aneurysmal disease, very rare.
Thank you very much. Well,
Pleasure.
thank you very much.
Yeah.
Thank you so much, sir, and have a wonderful day. And
Thank you. I'll celebrate with my daughter. She's gone for a walk. Thank you so much, Professor Khanna.
Okay, okay.
thank you so much. Please convey our best wishes to her for her good future.
Stay safe, Prof. And my wishes to Stephen as well.
Yes.
Oh,
Take
well,
care of
yeah.
yourself.
Thank you. Wonderful. Thank you so much.
Bye-bye.
Okay.